Hi everyone, so our presentation is on cognitive theory and social work. Our group members include Kayla Lasseter, Narda Mendoza-Leal, Rochele Andrade-Hackett, and Genesis Gonzalez. What is cognitive theory? It is the way individuals become capable of receiving, processing, and behaving on information. According to Bandura, as humans, we have no way of predicting or knowing what the future holds. However, with our cognitive ability, we can anticipate. This creates motivation, goals, and thought process for situations. According to McGuire, cognitive theory explains how our understanding of a situation causes dysfunctional and disordered responses, actions, attitudes, and emotions, and eventually seeing the world in either black or white. Langer and Leeds explain that this theory is a mid-level theory which provides guidance in social work practice and intervention. Basic assumptions. Pioneers in the cognitive approach liken the brain to a computer. While the behavioral approach mainly observes and addresses external behaviors, cognitive theorists are most interested in the cognition or the mental processes that inform behavior. According to Atami, some basic assumptions of cognitive theory and practice include limited capacity, control mechanism, and two-way flow. Limited capacity says that our brains can only process a fixed amount of information at one time. For example, our brains have a threshold of data we can work with at one time, just like a computer has limits to content and functions it can perform concurrently before it crashes and shuts down. Second, the control mechanism describes an area of the brain that has superior processing power, and it has the ability to impact other areas of the brain. Finally, the two-way flow understands that our brains receive inputs, information from the environment gathered through our five senses and experiences. Our brain organizes this information and uses it to inform our behavior or outputs. Practice principles. In our mid-level theories lecture, we learned that the grounding principles of cognitive theory suggest that thoughts influence emotions and behaviors, and that the behavior can influence emotions and thoughts. Therefore, practice principles involve two purposes. The interventions aim to challenge and confront the client when they report a distorted thought, and to encourage clients to reassess their belief with an alternative thought. Beck further explains that the development of reversing automatic thoughts include focusing and becoming aware that they are happening, as well as examining thoughts, since these thoughts are usually an exaggeration. 6 cognitive models used. According to Beck's cognitive model, cognitive schemas predict a person's responses. What are schemas? According to Langer and Leeds, schemas are broader than our automatic thoughts. Schemas can be thought of as a lens or a worldview with which we use to understand the world. The development of schemas begins in our earliest years of life and continues as we age. Schemas can be helpful or harmful to clients. Cognitive therapy, cognitive behavioral intervention, constructivism, problem solving, self-instruction, and rationale and motive therapy are treatments used to intervene. Cognitive theory practice settings. Trauma-focused cognitive therapy. Cognitive theory interventions are used across various heterogeneous community practice settings for trauma-exposed youth, particularly used in residential treatment settings, foster care, juvenile detention agencies, and in mental health practice during screening and assessments. Trauma-focused cognitive theory implementation. The implementation of cognitive theory in community practice settings is useful in reducing present and past effects of trauma, reducing PTSD symptoms, improving social relationships, decreasing emotionally disturbed thoughts, and reducing behavioral problems. TFCBT is also shown to work extremely well in these settings in treating children and adolescents with concurrent conditions including depression, anxiety, behavioral problems, relationship and attachment problems, and academic difficulties, as shown by Donish in the article, The Large-Scale Implementation of Trauma-Focused Cognitive Behavioral Therapy. Implementation for adults. As for adults, Rollinson states that cognitive theory is shown to be used in clinical and research settings for therapy of psychosis and assessing and coping with psychotic symptoms. It is greatly used in outpatient practice settings for therapy in OCD, MDD, and schizoid personality disorder. It is significantly helpful in the military setting for veterans with chronic PTSD, and highly effective in group settings that integrate mindfulness activities, as illustrated by Edusohan, Moiser, Sloan, Warren, and Thomas. Strengths according to Beck and Dezoy. It is well known that cognitive theory is a base of cognitive behavior therapy, which has brought great benefits to mental disorders such as depression, suicide prevention, anxiety disorders, personality disorders, substance abuse, and schizophrenia. It has been widely used in behavioral health disciplines and health professions. Its focus is on the individual's thought process. A problem starts in faulty cognitions that lead to maladaptive responses. Cognitive therapy helps shift the unhelpful cognitive into evidence-based and adaptive thoughts. It encourages a person to become scientific investigators of their thinking. With the professional's help, the person learns to change their thoughts while incorporating coping strategies and problem-solving skills. Cognitive treatment is time limited, going from 12 to 24 sessions every week. In the beginning, the professional works in creating a strong alliance with the client. In the end, the client develops the ability and confidence to apply the learned skills. It uses homework given to the client to put into practice the newly learned skill in real life. Homework provides the client with an opportunity to improve the mastery and generalization of skills in other areas. Research results show that CT is also useful in depression and anxiety comorbid with medical illnesses such as chronic pain, back pain, sleep disorders, and more. Beck and Desoy mentioned that CT has shown significant benefits in helping patients with psychological outcomes, treatment adherence, improved coping mechanisms with pain, and physiological indices due to stress, decreased blood pressure, enhanced immune response. This table shows the efficacy findings by disorder or problem. Limitations. Langer and Leeds presented some of the limitations regarding both theories because they focus on the individual functioning rather than the influences of the macro system. This limitation affects practitioners' macro-level work as it does not pay too much attention to the in-person perspective conditions. The cognitive theory does not consider the interaction between the person and the environment and how society affects our behaviors and cognition. The cognitive theory focuses mainly on the person and their closest systems, leaving the macro system aside. Professionals working on the meso and macro levels of social work may benefit less from this theory. Our profession advocates for the client's self-determination and autonomy, and the cognitive theory may manipulate the client's thoughts. Many people are concerned about marginalized and underprivileged groups having to adapt to values and norms established by the dominant society. Takeaway on cognitive theory. Overall, cognitive theory is used in various practice settings in order to challenge a client's faulty cognitions or understandings that naturally derail them towards inappropriate or dysfunctional responses, behaviors, attitudes, or feelings. Thus, diverse practice settings are necessary to meet the needs of these individuals across a larger scale to challenge these clients to understand that these thoughts and assumptions are in fact distorted or false. With the help of cognitive restructuring, social workers can help to modify the client's conscious perceptions and ideas until they are more appropriate and rational. Social workers may also use these settings to help clients think and therefore behave in a more constructive, consistent, or behaviorally appropriate manner. That was the end of our presentation. The next two slides are a list of our references. Thank you.